guys some practice, okay? There's not very much left to this. It's just the rest of the lower extremity, a couple of key named things, but let's talk. Okay, what's going on here? Normal. What's going on the other side? What do we think? What's my diagnosis? Okay, so so I'm okay with that, right? So joint shortening, all right, so what are we recognizing? We're recognizing the lack of joint spacing. What was the lack of joint spacing, and what other abnormalities do we see on here? Okay, thought I heard someone say it, osteophytes. So what condition have we talked about so far that causes a decrease in joint spacing, osteophytes, right? Okay, so you went even deeper, right? I heard primary osteoarthritis. I was hoping just for osteoarthritis, but taking the next step. Because in the next thing, so osteoarthritis, right? Correct. Weight-bearing joint, like we talked about, no spacing, bone on bone, as we discussed in the previous things. Then my next question becomes, primary or secondary? Well, we said primary. Why did you say primary? It's bilateral, right? Your secondary is usually unilateral. Primary, probably presenting with an older patient, right, that's lived life, or has had a job and has had wear and tear on the knees, not any trauma, not any surgeries, just repetitive wear and tear on the knees over time, so I get my bilateral osteoarthritis. Primary. If it was secondary, it would be unilateral, usually due to some type of injury or surgery or trauma to that joint, causing a secondary osteoarthritis from the injury. All right, good. That's all. That's it for the knee. All right, what we covered yesterday in that, just giving you an idea what the knee kind of looks like, and that's, osteoarthritis stuff. So leg. There's your anatomy. We have a tibia and a fibula. This is going to be very similar to the forearm. All right, a radius and an ulna, a tibia and a fibula. There's my AP X-ray. I have both joints, the knee joint and the ankle joint, because I need to get that to see the entire tibia and fibula. Okay, so they're two long bones. Don't get tied up again with the shadows at the ends of the bone, right? They go over each other, so you got to trace that cortex well, so that way you don't get tricked into think that this radiolucency here in the tibia is actually a fracture. It's just the way the shadows are presenting because the fibula is sitting right there, right? The way it comes across. And the cortex of the fibula right next to it makes it look a little bit darker. It's really not. It just looks like in a relationship to the superimposition area of the tibia and fibula there, because those are superimposed on one another. So those are actually more radio-opaque. Almost sometimes might make it look like a fracture, but that's why you got to follow your cortices all the way around. There's a lateral. Again, you can overlap in the superior and inferior portions, or proximal and distal portions. So knowing your anatomy there, just tailor dome. This little center area here, which we'll get to when we get to the ankle and the foot, notice that there's a small radiolucent kind of circle right there. We'll talk about that in a little bit and what that's called. That's actually one of the few things I think that you haven't had in anatomy class yet, but I'm going to tell you what that is so you know it's normal. Here's a pediatric one. Right, got those growth plates and a pediatric lateral. So, I have a 24-year-old male with an ED, status post an injury while playing football. He took a direct blow from a diving tackler's helmet. An X-ray is ordered to further evaluate. Please describe this image. Okay, so let's start with what's that? Okay, so I got mid-shaft, simple tibia and fibula fracture. Good. Other words that we could use? Transverse. I think I already know what you're going to ask. Go ahead.
Spiral tibia.
Ah, question mark. How many say spiral? How many say just regular transverse? Direct blow. Right? This is one of those situations where I recognize this might be construed as potential spiral, but remember, spiral is a advancement of an oblique fracture, not a transverse fracture, but then also the fact that I gave you the mechanism of injury to tell you it was a direct blow, so not a rotational force. So this is one of those examples to where, does it look spiral, does it not? You're not really sure. Kind of talks about that depth he was talking about, but it's kind of trying to, let me go back to the injury. Okay, the injury is a direct blow. Yes?
If it was a spiral, would you also see it in the fibula? Like just a
Not necessarily. You can have a spiral tibial fracture with a transverse fibular fracture. Two separate bones can be injured differently. They don't always have to be the same type of fracture. Yeah?
So are we calling that a transverse
It is a transverse. In this case, it would be a transverse fracture. Straight across. It is, but it's still, the fracture line is straight across, right? Horizontal, straight across the main part of the bone. Good. I'm not going to test you on this. This is in here for a couple of reasons. One, you're probably going to see it in ortho. And two, this is something that you cannot miss in clinic. This is the Mason-Yeo fracture. I don't do French, right? It's French. Mason-Yeo. It's not Nueve, it's not French and Spanish. It's good. I say that because that's what I call it in my head before I learned how to say it. It's like Mason-Yeo fracture. What it is it's a spiral fracture of the proximal third of the fibula. Proximal third of the fibula, where the root arrow is, right? Difficult to tell that spiral from this picture, but I'm just giving you the definition of it. It's a spiral fracture of the proximal third of the fibula with a tear of the distal tibular fibular syndesmosis. So all of that to say that you get a larger joint space medially on the ankle in question. Why do I show this to you? We're going to look at a mortise joint in the ankle. Most of the time, you're going to be ordering, potentially, just an ankle x-ray. Just an ankle x-ray. If you get an ankle x-ray with widening of the medial area of the mortise joint, or mortise, depending on how you say it, you're not done. Make sure you get the upper part of the leg to make sure you're not missing a fibular fracture in the proximal third. This is an extremely unstable leg because of both of those. We've lost the connection here due to the tearing of syndesmosis in the interosseous membrane, and we don't have the support in the fibula, which is designed to give us some of that vertical support in the leg. Do not miss this, because this can easily just turn into, hey, let's just go ahead and splint it or whatever for now, go home, we'll see ortho later, that kind of thing, and you miss this, the leg is going to break and snap even further. Yes, sir? So it's going to be a trauma type injury, right? There's not anything specific that I was able to find that's like it's always this kind. A lot of times it's usually athletic. It's kind of like the football one we talked about, but maybe the hit, instead of being lower on the leg, was upper, which is what caused the fracture, but then they kind of like got hit or fell and then rolled their ankle, right? So you're like, oh, my ankle's kind of sore, I rolled my ankle, but the leg is a little sore, that's why I got hit, but it's really the ankle that's bothering you the most, because that tear is going to be much more painful than the upper part, than the fibular fracture. Because this is tearing not just the syndesmosis, but also the interosseous membrane, so like that is going to be smoking hot painful. And so they're going to come in with ankle pain, right? When you see this, make sure you get this, Mason-Yeo. Okay. No? Click, click. There we go. So, it's technically in the lower leg part because it's the fibula. I want to make sure you get in that aspect. Again, I'm not going to put that on a test for you, but you will see it again, and this is one of those things you cannot miss in clinic. All right, ankle joint, anatomy. So here's your normal AP ankle, right, lower tib fib. Notice that the normal AP ankle, you can't really make out that joint spacing that well between the talus and the fibula, right? And especially in this corner here where the tibia and the fibula are kind of together, right? It's my normal AP ankle, got my malleoli. Then we get what's called a mortise or a mortise or an oblique. They rotate it about 15 to 20 degrees and take another picture. What it does is it opens up this joint space. So now I say, here's what normal looks like. There's the abnormal, right? Once you know what that normal mortise joint looks like, this stands out more, so it's, you won't miss it when you're out there in clinic. Because it should look the same, small, all the way across. That's evaluating the mortise joint there. And then we have our lateral. Pediatrics. Just a lateral in the pediatrics, because an AP and a lateral, they'll still do a mortise joint, but it looks the same. CT scan. What kind of slice is this? Coronal. What kind of slice is this? Good. Anybody know what that little center spot in there is? It's called the sinus tarsi. It's called the sinus tarsi. It's a little area in between the calcaneus and the talus that sits there. That is normal. That is not a fracture. I don't think you guys learn it in A&P. I say that because when I first started teaching this course, I said it like it was common knowledge, and I got like 67 blank stares. And so then you guys are like, no, they don't teach us that. Okay, so that is normal on a CT to see. A lot of times you will see it on your lateral. It tells the x-ray techs they got a good lateral if they can get right down into that sinus tarsi and make that nice little kind of round circular hole form. But these are the kinds of things we're looking out for. So again, if I were to see something like this, even though my fibula is fractured, I'm still gonna get the top part too, because just to make sure. But the issue with that is this here is I have my answer. I have an unstable ankle. I have an unstable lower leg. Because you can do this, and if the fibula is still intact, they're still stabilized, right? They have that man-made splits in the fibula, kind of holding things where it needs to go. But when you have fractures in both, this is unstable, they should be non-weight bearing. Okay. Taylor dome osteochondral defect. Does this look acute or chronic to you guys? Chronic? Why? Right? Biggest thing is, look at my talus. Doesn't it kind of look like there's a cortex in that little kind of curved area there? Right? If I follow my cortices all the way around, I come up, it's brighter white than the medullary area. So it appears that this may be chronic. Now the funny part about that is osteochondral injuries are usually kind of painful. So the fact that they haven't come in, maybe it wasn't bothering them, maybe they just didn't realize they did anything wrong with it. But this is looks like a chronic fracture due to the cortice forming around the rest of that talus there. Just kind of isolating that fragment there. So if I didn't have any type of brighter gray or white, radio opaque area there, right here, then I would say it's more of an acute fracture, but this looks chronic to me. Are you gonna see that on x-ray? Maybe, right? That's really small, and that's about halfway into the foot and ankle, into the bone with this where the CT is at. So you might see it on x-ray, you might not. Showing you normal versus a talus fracture. Talus fractures in particular, if you notice a trend here, I've now got 2 talus fractures, and they both have been what kind of modality? What kind of modality are we using here? CT. That's okay, you're good. Right? Talus fractures are really hard to see on x-ray, a lot of the times. They can be really hard to see on x-ray because they got a bunch of other stuff in the way. They got the ankle in the way when you get the foot, they got, the calcaneus is sitting there on some of the views. So they can be hard to see sometimes on x-ray. So CT is commonly used for talus fractures. But the ankle is basically knowing what your normal looks like. I'll go through it one more time, right? Knowing what your A&P is, what your mortise joint spacing is, right? Joint alignment, joint spacing, part of your systematic process. So when there's an abnormality, you got something to look at, something to pull out. Know what your lateral looks like. And just like a lot of the other stuff now we've gotten there, using the tools you've learned to describe the types of fractures you see or abnormalities that you notice within these images when it's not normal. There's nothing special about the TIG fib outside of the Mason Neal, which I'm not going to test you on. or anything special about the ankle that is named a special way. It's just being able to describe the fractures that we talked about. Okay. Foot, anatomy, x-ray. Okay, so a little bit different here, but kind of like the wrist in the aspect to where I can make out my medial and my intermediate cuneiforms. Lateral's kind of hard to tell because the cuboid kind of goes over it. I can see my navicular, but like I was saying, look at my talus, right? It's kind of hard to make out here. Hard to make out the talus sitting in these areas. You can make out the first two cuneiforms, but not necessarily the third one, right? Dorsal plantar view or PA foot, whatever you want to call that. But that's also why we do an oblique. Much like the wrist, rotate the foot up a few 15, 20, 30 degrees, and now my medial and my intermediate are overlap, but that's okay because they're isolated here. But now my oblique, now I can make out all the joint space. I can see my lateral cuneiform, my cuboid, my navicular, see my talus a little bit better, see my calcaneus somewhat, right? And now I can make out all of those tarsals in the joint spaces. Oh, don't forget all the phalanges too. Remember, your big toe is your first toe. Your thumb is your first finger. Don't forget that. Okay. Lateral foot, much like the wrist, doesn't give me tons of information on my metatarsals and my phalanges, or really my tarsals, unless something is dislocated, right? Or displaced. That's where this really comes into play. Got my sesamoid bones at the bottom again, very common to have there. Get a nice view of my calcaneus. I guess you use either word. Got my good view of that, but we have dedicated images for the heel or the calcaneus as well. Use a CT, just like the ankle. It's going to use to get more details. Here's what a foot MRI looks like. Again, I make it important to look at it and look at how I got two different MRIs. Things are two different colors. Do not assume fluid is white or fluid is dark on an MRI. It depends on the field that they do it in, and you don't need to worry about that. Got it. What do we got going on here? Somebody asked me about this like a week ago. We were going to see something like this. An avulsion fracture of what? Of the calcaneus, but from the Achilles tendon. This is an avulsion fracture from the Achilles tendon. It was ripped it right off of where it attached to that calcaneus. That takes some force, right? But a lot of times, you don't realize it really. They're going to come in because they think they tore their Achilles, which they kind of did in the same aspect, but not the entire Achilles has to be torn in order to have this happen, right? The Achilles is a big, thick tendon. You can see it kind of coming down here. See that radiolucency in the soft tissue? Right here. It's one of the few tendons we can see on x-ray a lot of the times because it's just so thick and dense that it shows up in the surrounding soft tissue as something that's a little more radiolucent. You can see it sitting in there. So that's the Achilles tendon causing a rupture. You guys are going to learn one simple test to do whether or not the Achilles tendon is actually ruptured. It's called the Thompson test. Just squeeze the calf, watch the foot do its thing. If it does its thing, you're good. If it doesn't, they tore their Achilles. Most common way these guys present, they're just going to come walking into you, maybe hobbling a little bit, but they're going to say, "Yeah, I was just standing. It felt like somebody threw a rock, hit me in the back of the leg. I looked back, there was nobody there." It does not hurt when it initially happens. It's just kind of like a pop. What's that? And you start walking again, and then about 5, 6, 7 steps down, you're like, "Ow!" And they can't walk as well anymore. It starts causing pain. These things will just snap. But that is an avulsion fracture of the Achilles tendon. This is not avulsion. This is a broken calcaneus. Right? Takes a lot of force. Which means, where else am I looking? Lumbar spine. Right? Definitely gonna do lower leg, but at a minimum, you gotta do the lumbar spine. Because if something like this happened, That energy had to go somewhere. And more often than not, it goes to the lumbar spine. That's what takes the brunt. And that's where you're going to see a potential compression fracture in somebody who's not osteoporotic maybe, or maybe a burst fracture from the high energy impact, something along those lines, right, is if you're going to have this. Don't worry about the Harris view for here. You'll learn that in ortho next semester. But we see this often in your roofers, your construction workers, they fell off something from great height, landing, fraction of the calcaneus, make sure you take a look at the lumbar spine. Okay. Very few things in the lower extremity we have talked about that have been like super important, must know, and testable. Liz Franck is one of them. Okay? This is an injury from disruption between the medial cuneiform and the second metatarsal. We're going to take a look at the pictures look like. Typically, we get rotational force of the forefoot or plantar hyperflexion with axial loading. Right? Plantar hyperflexion with axial loading. So this is dorsiflex, this is plantar flex, and I had axial loading on it. It's a weird position to be in. Usually we'll see this with like the running, kind of stepped in a hole I didn't see as I went to go plant my foot, hit, twisted, fell, right? That kind of stuff. Motor vehicle accidents is common. Step on staircase, falls forward, plantar flex foot, all that. What it does, it displaces the second metatarsal dorsally. X-ray is going to be your initial test. However, you must get weight-bearing X-rays. If you don't get weight-bearing X-rays, much like the AC joints, you will miss this. Okay? MRI is your study of choice if the X-ray is not conclusive. And we'll talk about here in a second a physical exam finding that is going to help you. These numbers, 2.7 millimeters, 2 million, good to know, not testing you on it. Ortho might, I'm not going to. But this is what we end up seeing. The blue arrow is the abnormality. The widened joint space in between the first and second metatarsal at the base, right around the cuneiform. You get a rupture there, and that is no longer being held together. Now, on the bilateral foot x-ray, what I have is normal, abnormal. Now you're sitting there looking at it going, man, that does not look like a very wide joint space, and I agree. But when in comparison to the other foot for this patient, it stands out. Look how small the joint space is here, and then look at the width of it there. Same thing. Look how small the joint space is in this area, and then look at the width there. If you do not do weight bearing, you will miss it. Okay. Because what happens is the ligaments that are in here are supposed to hold everything together. And when you're not weight bearing, they don't need to do their job because everything's going to sit where it needs to. When you put the weight, you put the pressure on, the ligament holds it together. If it's not there, it splits apart. The one physical exam sign that you should look on all your patients if you are concerned with this type of injury, take off their shoe and sock. It's like the diabetics. Take off their shoe and sock. It may be stinky and gross, but do it. You're a medical provider. And look at the bottom of their foot. If their injury pattern fits the Liz Franck, and the x-ray is negative, and you ordered it correctly as weight bearing, but they have bruising on the plantar surface of their foot, right around the base of the first and second metatarsal, MRI. MRI. Many of these, not all of them, but many of these injuries will lead to some ecchymosis on the plantar surface of the foot. It's not going to be on the top of the foot. It's not going to be on the dorsal surface. It's going to be on the plantar surface. So look at the bottom of their feet. You don't need an MRI if you look at the bottom of their feet and you see the bruising and you order the x-ray weight bearing and the x-ray shows the Liz Franck thing. Unless ortho or podiatry says, I need an MRI before they come and see me, okay, fine. But you don't have to because you just diagnosed the patient. right? In this case, the MRI is the study of choice if your x-ray is negative, but you have a clinical suspicion for a Lisfranc injury, because that will be able to check the area where it's supposed to be connected and find out if it's torn or not. Look at that gap. Questions on Lisfranc? This here is showing you apial oblique, right? We got fractures of the third, fourth, and fifth metatarsals. But why we get those different views, it kind of helps us with displacement and things along those lines of what's going on. Normal over here. This is a very poorly positioned lateral foot. Ideally, I would want all of these metatarsals in one nice stacked line like I showed you on those first images. Sometimes you get a crap x-ray tech, and this is what you get. This lateral is showing you, this actually works out for this lateral, is because I'm missing something there. Can you see what we're missing? Yeah, bone. Bone. This is going to be some of that osteomyelitis that came from a diabetic ulcer, right? Got in here, started eating away at that bone. That's what the lateral showing on that one. Different than the regular fractures of the apial oblique. Okay, Jones fracture. Transverse fracture of the base of the fifth metatarsal. Not a fracture of the head of the fifth metacarpal, which is the boxer's fracture. Also, not a fracture at the base that's intra-articular of the first metacarpal, which is the Rolandos or the Bennett's. This is now a fracture at the base of the fifth metatarsal, and this is your Jones fracture. Why is this so important? Take a look at the blood supply. Very similar to the scaphoid and the femoral head, to where we could end up with avascular necrosis, but the majority of these Jones fractures are surgical in nature. They're going to have to surgerize it, put a screw in there, make sure it comes back together. Very high chance of a non-union because of that poor blood supply. So this word's an ortho or a podiatrist call when you do see this. Just know the Jones fracture is a transverse fracture of the base of the fifth metatarsal. Oop. Yes, yes, anybody? Yes. Amputation? So some patients, when things like this happen, they think it's really important if they bring in the extra parts. And this is what happened. This was a patient who came into the ER. I can't remember what caused the amputation, but they had the amputation and they brought their toes in. And so when you go to the hospital, if you bring those parts, they're gonna take a picture of all of it, right? And so that's what they did. So there you go. You can't fix that. It's not like the dentist where you put your tooth in milk. It's gonna be okay. It's not gonna be okay. Okay. What we got here? It actually says it. Tuft fracture, you'll see it in the fingers sometimes too. It's where the nail connects to the bone in that distal phalanx, right? You can have that crush injury, that crush fracture is called a tuft fracture. The key thing with that, if there's blood in the nail, or you see blood coming out, it's often an open fracture. It doesn't get thought of as an open fracture because usually it's just a smush injury. But again, if there's any blood or any opening to the outside world, that's an open fracture. Treat it with the appropriate antibiotics, which you guys started today. Yeah. Look him up. Always look him up. What's this? Gout. That's pros. Beautiful. What do we got here? Second and third metatarsal transverse fracture. Boom and boom. Here and here. Good. What is that? Layman's terms, heel spur. Medical terms, calcaneal osteophyte, right? So what comes in here? Achilles tendon, that we talked about, reasons that things calcify, inflammation, pain, long-term type stuff. This person may be a runner, maybe athletic, right? Constantly kind of pulling on that Achilles, causing some pain or some discomfort. And so the body's like, enough of this, I'm just gonna calcify it so I have less nerve endings. And so that's kind of what happens. Usually we leave them alone. If they are causing significant pain, discomfort, or functional disability, then you can refer them for surgery and they'll go in and shave them down. But shaving them down doesn't mean they won't come back. So use surgery as an option, but as kind of like a last resort option for these things. Any bone spurs anywhere. Surgery is a last resort option when it's causing them significant issues. What do we call that? Jones, not boxers, not Venice, not Rolando's, Jones. And that is everything in radiology block 1. Congratulations. You can now diagnose all of your active military people with their profiles. Rock on. Questions? Alright. Take 7 minutes till 5 after. Use the bathroom. Here's what you're gonna do. I'm gonna pull up the practice, and then you guys can self-assess, and we're gonna see where you guys are sitting at, okay? And no new material. Give me a few minutes.
Sir. This one from his like
I want more pictures.
Yeah, I'll look at it more. At least the reason something like this, you got
She's doing the right thing. She should have did it with that's why we don't use osteophytes in patients. We say, hey, let's not generic SOP. what arthritis is. We know that anybody has these joint things, right? But we can tell them.
So I can look at it normal, I can throw it. And I can tell them.
Every test from now on, you know.
I'm not.
You got measurements. Look, you're like, you gotta go
Look at how smooth it is. So arthritis can't get bad enough if you start sucking. Now remember, dislocation is complete separation. Yes, some arthritis is particularly these and some. Because it will get worse and worse and worse, and it will even shift even more. There is a little bit of subluxation. Without a whole replacement, correct. Just pulling up the. Pulling up Here's the process.
Before I start major lift, just getting kicked out, make me good on all my training, that's all I need.
Alright. Ready for some last stuff? Okay, I am not Major Denius. He used to be an ortho instructor here, he's the one who created this for me, he used to kind of teach it during this lab portion, but he left. And that was his choice to do, to be the one to teach this section. It's a really good slideshow, so I kept it, and I wanna keep giving him the credit for it, even though I'm the one doing it now. And I didn't wanna burden Major Davalos, because he didn't agree to do this, but Major Denius did, so. So what this is going to look like is we are going to go over cases, right? And I'm not gonna want feedback initially, like verbally, like you guys have been doing and stuff like that, which has been great. Thank you for the engagement, for those who have been humoring me and answering my questions, trying to pull stuff out, even if it is mumbles. Appreciate it. It's better to make it more interactive, but we're gonna go through some stuff and kind of give you an idea of some of the things you could see, or not see, but style that you could see on this exam, or just on your phase 2 exams, or pants, right? The kind of stuff that they're gonna give you to kind of start to get you in that patient vignette mindset mode, which is a lot different than freshman semester when it was, what goes here? What is this, right? That's how the questions were last semester for the most part. So we're gonna go through some of that. So as a quick recap, on these ones, green is gonna be normal, red is gonna be abnormal if they're all outlined. But it could be something as simple as describe the fracture. Femur shaft fracture with apex lateral angulation. Does everybody see the apex lateral angulation? Right? For those who are in Canvas who are looking for it, it's down in the Block 1 lab. It'll be under there if you're looking to download it. I think I told you you have to look at it beforehand. Apex lateral angulation, is that a right or a left femur? Left. Left. You have enough context clues. Okay. There's the owie. Shortening, also okay, if you want to use shortening on this, right? If you wanted to use medial displacement, also okay, because the distal fragment is displaced medially from the proximal fragment, also okay. Right? Okay. You've seen this one, it's in the slides. Hopefully by now you have a systematic process. If not, find one quick. Got 6 days for you to find a systematic process. Okay. Here we go. 15-year-old female comes to the clinic with left ankle pain after falling off a climbing wall 2 days ago. Pain is 4 out of 10, localized to the ankle, described as sharp, better with Tylenol and rest. Okay. She's a well-developed, well-nourished female. No active distress, no acute distress, however you want to look at that. Sitting comfortably with mock. What is mock? Anybody? No? Mother of child. It's an abbreviation for mother of child. But she's favoring her left lower extremity when walking. So visual inspection, looks fine. Which means I don't see any bruising, I don't see any swelling, I don't see anything at all. She is positive for tenderness and palpation over the anteromedial left ankle. But she's got full active range of motion and passive range of motion. That's what that means, AROM and PROM. Active range of motion means the patient is doing the movement. Passive range of motion means you as the provider do the movement. Okay? Of her knee, foot, toes, but decreased active with ankle due to pain. Her strength is 4 out of 5 in her ankle with pain. We didn't do any special tests, that's not applicable. She's neurovascularly intact. That means we checked her CAT refill, we checked her pulses, that's all intact. Checked her sensation. Now I can't fit all of this on an exam question, but I can put the pertinent physical exam findings along with the history and a vignette. Okay, so we've got all the information we need as our provider. Are you gonna order images? It's a radiology course, yes. We're not gonna order images, right? It would be silly of me to give you one that you're not going to. Good, what are you gonna order? All right, ankle x-ray, left, preferably, that's the one that hurts. What's your history gonna be? What are you writing on this order?
We're supposed to answer.
So when we get to the x-ray, don't answer, but right now, yeah.
Left anterior medial, or left anterior ankle pain. Where she was complaining is basically
Okay, mechanism of injury, where the pain's at, age, important, right? And how long it's been going on for. So if we go back to this, I would say 15-year-old female with left ankle pain after falling off climbing wall 2 days ago, pain or tentative palpation over anteromedial left ankle. Done, sir.
So question, so when you said she's favoring extremity, does that mean she's like using that one more or less?
Yeah, oh, good question, right? Favoring an extremity, what does that mean? Using it more or less. It means favoring means she's paying attention to it. So using it probably a little less, maybe limping. Favoring means that she is favoring it. In other words, when you walk around, you don't pay attention to anything you walk around. But when you favor something, you're focused on it. And so you're being very careful with it, very ginger with it. That's what favoring means. Thank you for asking. Yeah, I know you guys are still learning some of this stuff, so like if there are words that don't process, let me know so I can explain them, please. Because I recognize that you're still kind of early on in the sophomore semester. Okay, so yeah, you read the order. Okay, so I got my x-ray. This is the part where I want you guys to do your thing. Give you a little while to go through it. Some of you are already there on your slides, so I'll be nice and go to this one for those of you that are using the screen. I'll even give you a normal next to the abnormal. It will not be like that on the test. Sorry. But you're still in learning stage right now, so I'll give it to you. This is true. I'm still in the learning stage. You know the day to quit your job in this field? The day, what did you say? When you stop being scared. The day you wake up thinking there ain't nothing that can walk into and surprise me and I know it all, when you walk to go see patients, that's the day you need to leave medicine. You never be confident, that confident on every patient. Alright, are we good? Okay. How many found this? Yeah. Now the real question. How many correctly classified it as this? Type 3. Salter-Harris type 3. How many of you saw, oh yeah, go ahead.
Is the growth plate weaker than the rest of the bone?
I wouldn't use those terms per se, what are you thinking?
Is it more susceptible to being broken?
So it's not necessarily more susceptible to being broken. It is an area of least resistance for energy. I think that's a good way to describe it, right? When you fall and you hurt yourself in the pediatric, energy's gotta go somewhere, and because that growth plate isn't solidified yet, it is an area of least resistance, so it is common for the energy to go in there and cause issues. What's that? Growth plates. Oh. But remember, right? But don't feel bad about that, because that is the physes, that is the growth plate. But do you remember, look at the picture. Where does the fracture go? It goes through the physes and through the epiphysis, right? The energy had to come out and go somewhere. So technically it's part of the fracture. Now the good part about that is you don't need that to get to a Salter-Harris 3 because you did without it, because it's through, we assume that if it's in the epiphysis or in the metaphysis and involves the physes, that the fracture is also in that area, but you can't distinguish between the growth plate and the fracture, right? That physes, you can't distinguish between that. So technically, what this is showing is technically that is part of the fracture, because the Salter-Harris 3 isn't just this, right? It's this and through the rest of the growth plate. Does that make sense? What about that one?
It's similar to the non-broken.
It looks similar to the not broken one, but what's the difference? I don't have a fracture in the epiphysis of the fibula. It's a different bone, right? So it does look similar, but I also don't have a fracture in the metaphysis or the epiphysis, and if I draw my cortices, it's lined up, so I don't have a Salter-Harris 1. I don't have any slippage. So because there's no other abnormality, that's just the physes. Do you understand the difference? Yeah, go for it.
Should we look at like push weight as well, reach for the leg and lateral pain? A lot of
Yeah, so good question, right? So you could push on there and see if she's painful right over the fibula of that lateral ankle, and that will help give you more confidence that there's not a concern there. Yeah. Salter-Harris fracture of the distal tibia is the official diagnosis, answer, and what are we gonna do for them next semester? Yeah.
Would that be a case where you wanna order a fibula as well?
No, because it's not, remember that was the joint spacing concern, we were not the Salter-Harris.
Is that not positive?
It's a pediatrics. Yeah, it's less common in peds because again, they're bendy and the joint space is gonna be different. So,
Answer choices on the test would be a bunch of Salter-Harris options, or it'd be just a bunch of other types of fractures.
yes. A for effort, for sure. I can give you like, oh, I took his 2 points away for his sharpshooting earlier. If I can give you his 2 points, I would. That's not legal. But yes. Oh, there he is, he's back there, okay. Hiding in the back, okay? All right. And then in these slideshows, I have a quick review for you of the other Salter-Harrises. So if you're using this to study and test yourself, it's right there. Double check, remind yourself which of the Salter-Harrises are what, right? And remember, it can be tiny, right? Look at that Salter-Harris 4. Look at that small little fragment, that makes it a 4. That is a fracture of metaphysis as well. If I give you multiple images, I'm giving it to you for a reason. Okay. So now let's shift. We got a 24-year-old male who comes in with, female who comes in with 3 days of left groin pain, described as sharp, constant, 5 to 8 out of 10. That's my favorite. 0 to 10, what's the pain? Oh, like a 5 to an 8. Okay, great, thanks. Or 10, really? Yeah, it's a 10, it's terrible. And you're sitting here talking to me? Yeah, okay. Depending on activity, radiates from left lower back and left lower extremity. No relief with rice. Everybody know what that is? All right. NSAIDs, so like ibuprofen, heat, which is really funny because they almost never come in going, totally good the rice, NSAIDs, and heat thing, and it's still not getting better. What have you done with this? Nothing. Great. No trauma. Patient is an active duty firefighter who completes 2 CrossFit workouts daily. All right. So now, well, hang on a second, right? Now my brain goes, all right, this isn't a profile seeker, right? You're a firefighter, you do 2 CrossFits daily, you're coming in with groin pain, all right, great. Well-nourished, well-developed female, appeals uncomfortable on the exam table, but no acute distress. She has an antalgic gait. What does that mean? She's limping, and antalgic, like just kind of, she's coming in limping. Visual exam is unremarkable. Palpation, unremarkable. No tenderness to palpation. Limited left hip range of motion due to pain. Her strength is decreased 3 out of 5. This doesn't mean much to you yet, but positive straight leg raise and log roll test, neurovascular intact. You will learn what those tests are next semester, a little bit here this semester with Colonel Rogers, but. Did you order images? Yes. All right, what are we ordering? X-ray. Okay. How would you write the order? Go back here. 24-year-old female with 3 days of left groin pain, no trauma or injury noted. I would actually put in there, patient typically, not only the firefighter part, but patient typically does CrossFit twice daily, right? Give them something. Physical exam, really unremarkable for a radiologist. They don't really care about the strength, they care about palpation, where does it hurt, pain, that kind of stuff. So you order the hip x-ray, or the femur. Nice part about this area of the body, if you said pelvis, you would get this answer. If you said femur, you would get this answer. If you said hip, you would get this answer, because they all have the same part of the body that we're concerned about. I'm not really caring which one you would order, as long as you're in this general area, read your x-ray. A little bit less time on this one, just because it's an exact picture we've seen before in the slides. So there's our abnormal. There's my abnormal with positive yellow line sign. Did you guys see the femoral neck fracture? They may not see it. You want to point it out if you didn't. Okay? How do we find that? You can do your stepwise process, or again, knowing what normal looks like will make abnormal stand out. What are we going to do for them? You'll learn that next semester. That patient's probably going to get surgery, but.
Would that also be a skippy?
What's that?
Would that also?
Would it be a skiffy?
No.
What age population are skiffies in? Pediatrics. So I do not have a growth plate. I do not have pediatrics as an adult. So it is not a skiffy. Yes, sir.
Realistically, would somebody with an injury like that be responsible?
They can. Which is where the intelligent gait comes in. Probably coming in like significantly like favoring it, kind of limping and stuff like that. But they can walk on this and be in quite a bit of pain. And that's why like her pain is 5 to 8 out of 10. My guess is when she's walking it's an 8. And when she's just sitting chilling it's probably closer to a 5. Plus, you gotta figure, she's a firefighter who does CrossFit twice a day. She's probably got a high pain tolerance, right? And the ass, like, I'm always sore, so whatever, like, it just hurts more than usual. Alright. 63-year-old male comes in for follow-up of knee pain, has had worsening knee pain for many years, reports repeat minor traumas during his active duty time, and multiple courses of PT, physical therapy, not PT test, physical therapy, and knee injections, which are not helping anymore. He just wants relief so he can keep ice fishing in Alaska. Because anybody in the military who has ever been stationed up at J-Bear has spent their entire career trying to go back to J-Bear. I don't know why, it's just what they want to do. So, he retired, he wants to go back to J-Bear, and he wants ice fish in Alaska. I've never been, so that's why I say I don't know why. Must be something in the water. Well-nourished, well-developed male, no acute distress. Varus alignment of the lower extremities. Varus and valgus, remember those directions, right? That's what that's explaining. We'll see what that looks like on image here in a second. Bilateral medial joint tenderness to palpation. Limited active and passive range of motion in all planes. 5 out of 5 in symmetric is the strength. Unremarkable special test, which you'll learn all about. Neurovascularly intact. Wonderful. No pain scale. He's just achy. So yeah, we were one of these, right? X-rays, right? Okay. How are we gonna write this? 63-year-old male with chronic knee pain worsening over the past few years. Bilateral medial joint line tenderness, no other abnormalities. Please evaluate. No trauma or injury. That's a big one. No trauma or injury. Okay. And now you get your x-rays. We just saw these. Usually this is a separate day. Like I'm a little behind this semester. So it's not like we just saw this right here. So let's show you some things. Let's just go over it since we just saw that x-ray. What are those? Osteophytes. Remember, osteophytes are that overgrowth of bone. So I had a good question of like, hey, you said osteophytes and bone spur as well. You see them on the arthritis. Why? What is what? Well, they're all the same. Osteophytes is just overgrowth of bony area where it's not supposed to be there. Osteophytes is a medical term. We use things like heel spur for the patient so they understand what that is because they don't know what an osteophyte is. They're like, what's fighting? Like, I don't understand. What's going on? Right? Same thing with this, right? Arthritis. They know arthritis. They don't know osteophytes. So they don't call them and be like, hey, look at your x-ray. It shows that you have some osteophytes. So you have arthritic changes in your knees. Congratulations, right? Bone on bone. That's going to hurt for a while. This is why the injection stopped working. Okay. Subchondral sclerosis, hard to see on this image, but when you go back to your arthritis images, your primary and secondary arthritis, really your primary, you'll see the sclerosing. Really, it only happens when there's bone on bone in that area. Because what's happening is that bone is getting really irritated, so it's scarring up, and so you're getting that increased radiopaque area in there. Joint space narrowing, or lack thereof joint space, right? But narrowing in general. Bilateral knee osteoarthritis, what kind? Primary. Plan for him, probably bilateral knee replacement. Yes, sir.
At what point would you consider that significant joint to be subluxed?
So this would be partially subluxed, yes. Right? So I'm getting, look at right here, I'm leaning over, I don't have my alignment right here, I don't have my alignment right here. So for those that would want to call this some mild subluxation, absolutely appropriate. Right? With your really bad arthritis, particularly in the knees, subluxation is common, especially once they get to this bone-on-bone area. Usually, it's subluxed. The femurs go towards the medial aspect, and the tibials go out towards the lateral aspect most of the time, but it's not a guarantee. Yes, ma'am.
So where have the meniscus been all along?
So menisci, you can't see on X-ray, right? They're soft tissue. No, they're still there. They're still there, but you can't see them on X-ray anyways. Even if it was a healthy knee, right? That's soft tissue. So I can't see that on X-ray. If I wanted to evaluate the meniscus, I would need an MRI.
The bones are already captured.
And this meniscus are still there. They're still there. Have they torn them? Maybe. There might be some small tears in there. I don't know. But yeah, no, they're still there. It's the cartilage that actually wears down and goes away in prolonged arthritis. But you can't see that on X-ray either. So we just focus on what we can see in this course for right now. All right. 39-year-old male comes with 1 day of pain in his left ring finger. That was even nice. They put fourth digit on there for you. After getting his hand tangled in a rope while on a cattle drive. If this is not a patient from Texas, I don't know what is. Pain is 5 out of 10. Worse with movement. Localized to the proximal ring finger. Rice has helped a lot. Along with some topical salve from his grandfather had left over from an injury 10 years ago. That's exactly, yeah, it's tiger balm, right? Or, well, I've been taking these pills, my wife, my favorite when they come in, like, yeah, it was really bad, I took the Vicodin that I had for my knee surgery 3 years ago, you shouldn't do that. Now I hope you don't get popped for a pee test, but it happens, you laugh, I'm telling you. Or I thought it was infected, so I took the leftover antibiotics from when my wife had pneumonia a couple of months ago. So wait, you're telling me she never finished her antibiotics and then you just started randomly taking it? I don't want to hear any of this. Like, let's just, you're gonna hear some stuff, I'm telling you. All right, well-nourished, well-developed male and no acute distress. Vital signs, WNL, vital signs within normal limits. Okay? So he's stable. Visual, left ring finger swollen proximally. Positive for tenderness to palpation over proximal left ring and long finger. So fourth and third digit. Limited active range of motion in the left ring finger due to pain. 4 out of 5 strength in the left ring finger. There are no special tests for the finger. And he's neurovascularly intact. You know where the pictures? Hand and finger probably. What are we going to say on this one? Let's go 39-year-old male with 1 day of left fourth digit pain over proximal region after getting hand tangled in rope during cattle drive. Got it. Right? Mechanism of injury. What's it? Go ahead. Go for it.
Could you just simplify that to trauma? I mean,
No, you don't want to do trauma per se, because you could if you didn't have the details, right? But the details is going to be important even for the radiologist, because if you can describe the mechanism of injury, there are certain fractures that will do certain things.
right, like boxes, you hit a wall.
Correct, right? We talked about spiral versus not spiral, right? Do I have that rotational injury? So, they don't want to book, but if you could do in like 1 to 2 sentences where it hurts, how long it's been, and what happened, they would love that. And it would actually benefit you significantly. Good question. All right. Here's what we got. You notice how on every X-ray I have the systematic process? I have a systematic process. Let's go to the normal versus the abnormal, just so that way you can see it better for those that are using the screens up front. I'll make fun of stuff. Like you're the first one to laugh at stuff. You know, can't help it with genetics. It's Jeremy Lannister's hand X-ray. All right. Did you see the ring finger fracture? Did you stop there? Ooh, shiny toy, I'm done? I hope not, because I just turned it off. There we go. Because then there's one on the third finger as well. What is going on the fifth finger? Ah, soft tissue shadow. Good. Good. That could easily look like a fracture if you didn't do your systematic process and follow your soft tissue to make sure. That is the soft tissue of the fourth digit coming down over the bone, causing a difference in that shadow. Right there. That is a soft tissue shadow. That is not a fracture. Easy way to confirm that in clinic, you can do it just from image. Oh, did it hurt? All right, great. You have that advantage, but your radiologist doesn't, right? And that's where what's going on helps them sometimes. I mean, they can pull out soft tissue shadows, that's their job, but soft tissue shadow. Middle and ring finger, proximal phalanx fractures, discuss it later. Yes, sir.
So did you say on that fourth digit that there's some shortening or am I bad?
Possibly, I want more pictures. Yeah, there absolutely could be some shortening there, and to be honest, there is likely some displacement there as well, but I can't tell the direction with just this oblique photo. Yeah, good luck. What else we got on this one? Yep. Right. Let's do another one. You start to get a feel of what some of these might kind of start to look like now, right? Okay, give you the information you need. Again, I won't have this in depth of a physical exam on there. There's just not enough room on the test to do that, and some of these things you don't actually need for what we're assessing here. But 32-year-old male comes to your clinic with 1 day of right elbow pain after a falling injury. His pain is sharp, localized to the elbow with minimal radiation into the forearm. Pain is 2 out of 10 at rest, but 7 out of 10 with use. Rice and Tylenol have not helped so far. He's comfortable, he's well nourished and well developed, his vital signs are normal. Visual exam is unremarkable. But boy, when you push on that right lateral elbow, it hurts, but nowhere else. Full and active range of motion, full active and passive range of motion, you can do all the things. He's super strong, right? 5 out of 5. With pain though, he has 5 out of 5 strength, but it causes discomfort. No special test to do, neurovascularly intact. Here is the fracture. Or abnormality. Let's do this. Oh no, I didn't have extra pictures of that one. Whoops. Whoopsies.
You do after the answers.
All right. We all see the radial head fracture. Yeah. How many of you tried to find a posterior fat pad sign afterwards? Now, a few did, right? So now before I pointed out, do we need to look for the posterior fat pad sign on this x-ray? We do not, because the fracture is there, we see the fracture, we can diagnose the patient. So you don't need to find it on this x-ray, which means on the test, if you see a clear radial head fracture, don't spend additional time looking for a posterior fat pad because you found the abnormality. The posterior fat pad sign is designed for those elbow injuries that you don't see anything wrong on the x-ray and you're looking to confirm by having an absence of it, right? Or if it's there, then you know that there's one. But there is a very small posterior fat pad sign just behind the humerus right there. Probably easier to see on your screens. It is right behind the humerus, right there, small radial lucid area. But this is a radial head fracture. You will discuss what to treat it for as a junior. Right? I think they'll blow 3 pictures because he knows you already learned it. So here we go. Here's how we treat it. Ah. Alright. Yeah, right? This is the one you need to look for the fat pad sign. This is the one. I challenge you, find me the fracture. I love it. It's right there. I mean, it's there in the elbow. Why can't you see it? See, and this is a good one, right? Because you can do something like that. Because then when someone's like, well, how do you know it's there? It's like, boom, posterior fat pad. Right there. Bam, bam, bam. What does posterior fat pad mean? Yes, it means fracture, but it's there because of the hemarthrosis. Right? The fracture doesn't cause it. The bleeding from the fracture is what causes the posterior fat pad sign. So that one's an occult radial head fracture. The first one was a real one. Occult just basically means we can't see it. It's real. It's real. All right. Let's do another one. Let's do one more. Yeah, we'll see. That'll be the last one. I'll let you guys. 15-year-old male presents for a routine well-child exam. Routine. No issues. Mother of child asking to tell her son to stop eating so many damn donuts and put his phone away and go outside and play. Your kids nowadays, all they do is stare at their dang tablets. They don't go play at the park anymore. Right? But he said he doesn't want to because his hip hurts. Gosh. Well-nourished, well-developed, quite well-developed because he's an obese male. Or well-nourished. He's very well-nourished. No acute distress. Playing on his phone and eating cheese puffs during the encounter. That's it. We found him. It's Eric Cartman. I don't have the name, but there it is. Eating his cheesy poofs. It will not be that obvious on it. I'm not going to tell you that he's sitting there eating cheese puffs. Visual unremarkable. He is mildly tender palpation over his left. What is GT? Greater trochanter. Full active and passive range of motion. Strength 5 out of 5 and symmetric, but he's walking with a little bit of a limp. And you order the x-rays. And you say, that's too hard for me to see. I'm a novice, so I zoom in for you a little bit. And put a big red arrow. But I want you to focus on this one with the normal versus the abnormal. See how that works. Yes, sir.
You know what Throckmorton sign is? Have you ever heard of Throckmorton?
Yes, I know what Throckmorton
Is that real? I just
No, it's not really. It does not always point to the pain.
And you say the case is
Every semester, I hope, like every semester, I'm like, maybe this will be the one where somebody won't mention it, and it never fails. not a real thing.
That's a solid question.
Alright, come on, let's gather them together, alright? But, what I will say is that can be useful sometimes in the aspect to where, when you're trying to evaluate things, let's say somebody just throws you a pelvis x-ray, and you're trying to figure out, hey, that looks like a gap in the pubic symphysis, is that normal, is that not? Males should barely have any, females can have a little bit. You can use the soft tissue on a pelvis x-ray to tell you whether this is a male or a female. Just saying, that is real. But no, it does not always point towards the area of pain. Better you say it here than in case two, right?
Sorry,
Yeah, they get that on a report. Or if I'm just like, get out. Just get out. Alright, anyways, back to this, right? Skiffy, split capital femoral epiphysis, also known as Salter-Harris what? 1. Salter-Harris 1. It's in the name, slipped. There it is. There's that one again. Yes, you just had that one. Correct. Oh, remember this? Yes. Depressed skull on lateral x-ray. Which means then, if I see this, what's the next thing I'll probably get in? CT. With or without contrast? Without. There. Okay. You would like the other one. No, it has to. Don't get hung up. I know it says grade 2. I'm just telling you, yes, you do not need to. Yes, you do not. No, you do not need to know the grades. Yes, they're in the slide deck. You will probably learn them more in ortho. They will require you to know them. I don't need you to know that it's a grade 2. I need you to recognize the AC joint. And you don't need it because, remember, this should be down here. This should be a fairly continuous line to the top of that clavicle. I have that step off or that step up, however you want to look at it. So I would like to have the other AC joint to compare, but I don't need it when it's this abnormal. Remember, that should connect together quite nicely. If it was a normal AC joint, we have that separation. I got to step up, bless you, or step down. Okay. Let you look at this one for a few minutes, or a few seconds. We're getting close to the end. Just a couple more examples. And we're going to be out of here before 4. Let's take this at least 7 minutes of traffic. At least. All right. You guys see it? Oh yeah. As soon as you show me that, yep.
The person's gonna die.
Yeah, that's what that is. SH, poop. Poop, 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 poop. There will be at least one normal x-ray on the test. At least. At least. There will be more than one question with normal x-ray as an answer choice. So do not just look for normal and pick it and like, right? Don't do that. Don't do that.
There's 5 normals and a blue.
There could be 5. There will be at least one normal x-ray. At least. Guaranteed. I say that again, I said this before, but I'll say it again. If you've gone through your entire exam on Monday and you haven't chose normal, then either go, you know what, don't care, I'll take the -2, I'm not gonna play with that. Or go back and find one that changed the normal. Don't be mad at me if you change the abnormality to the normal or the normal to the abnormality because you wanted it, it's not my fault, right? But there will be at least one normal x-ray. At least. What is that? Oh, Rolando. Rolando. Uh-oh. 1, 2. 1, 2. And then I confirmed with Major Davalos on the SI joint, the dislocation, the subluxation, all that kind of stuff. He was right, he said they don't use those terms when it comes to the SI joint. They pretty much just use like separation or, what did he say? Separation was the big one, or dysfunction, SI joint dysfunction. That kind of tells them that there's been something going on with the SI joint. They do not use subluxation and dislocation, even though that's a joint in the medical world. What would you guys answer? Open both pelvic injury or pubic scissors, why you right SI joint? What's going on here? Not pass. You're separating the rest of the class. You're the lieutenant for crying out loud.
That's just part of his routine.
Yeah. Alright, anybody remember though, seriously, which way is it dislocated?
Anterior.
I thought I was gonna tell you. Yes, anterior, right? Femur going out laterally. That's it, guys. Questions, comments, concerns, not you. It has nothing to do with that, go ahead.
Just for the test.
For the test.
The majority are going to be reading these things, instead of just like question and answer, mostly it's gonna be reading extra. Either or, good mix?
It's gonna be about radio.
It's gonna be about radiology, I like that
I
answer.
like it.
There will be a mixture of both. There will be reading images, there will be just straight up answer the question, right? Especially in this block, because we did have quite a bit of material of like just simple questions, like let's say introductory info, yeah, introductory questions on there. And there will be image readings, there will be when you order, there will be all different types. There's not a magic formula. I don't have so many pictures and so many not pictures. Oh, as a reminder, right? Don't use the app. Also, there will be, I think there's only one question. There will be 5 answer choices at 5 different x-rays. And you have to choose the x-ray that goes with the situation, right? So there is, I think, one of those. I don't only do one just because that takes a lot of bandwidth. What was your question? That was, yes, yes. That is a urinary catheter for this patient. Urinary catheter. Good. What other questions do you guys have? I'm sure the class leader already told you, but I'm gonna say it too, like tomorrow, I'm gonna be peeking my head in and out, kind of right around the breaks. I do that not to be a creepy stalker guy, but I do have to be in here in case questions pop up before the review on Friday. So I'm available, so don't feel shy about coming up and asking me questions. If I'm in any of your clean skills labs this week, I don't know if you have any, and you see me down there, feel free to ask me questions, I'm good with it. I'm here tomorrow, I'm not here on Thursday. I'll be here Friday for the review at 12, it is optional. Optional review, Q&A, bring your questions, alright? You get out of it what you bring to the table. I am happy to clarify anything, okay?
Before you guys take off, I have some stuff from Ops.
Dun, dun, dun.